tell us their reactions or thoughts or initial reflections. I was very struck by Dr. Lucy's paper. I think if we could achieve even a fraction of training towards all those competencies expected of a 21st century clinician, we'll be doing well in our education programs. But Karen.
So I guess I wanted to ask a little bit about clarity around the messages around the patients that we're talking about, because I struggle a little bit about, I think absolutely there's this very clearly delineated, I would say, subset of patients who have a diagnosed mental health illness, one or more, as well as medical issues that you talked about, Paul. But that kind of then leads to the discussions and using terms like those patients or these kinds of patients. And I kind of think that what we're talking about is every single patient has both medical and mental health aspects of their health presentation. And so I guess I'm just thinking as we move forward talking about strategies and curriculum and how we're talking about this, that we have some sense of who we're talking about and how we're presenting that and what words and language we're using when we're actually talking about patients and what the focus is and what we need to learn.
So this tension has arisen even in the development of MPA initiatives, and more specifically, I think it boils down to this classic generalizability versus ability to evaluate. And I think that we need to find a way to capture the essence of the MPA while at the same time coming up with a way of defining our population such that we can actually evaluate it. And you know, so I think to put this in concrete examples, there's one MPA initiative where they thought that it would be a good idea to just ask primary care physicians to send complex patients. And that might be a good idea in terms of trying to meet the needs of the primary care physician. It's a terrible idea if you want to operationalize a system of care. And so I think there's going to remain this tension, and this is just a very lengthy way of completely dodging your question. I realize that, but I do think that there is something there, that the reality is that complexity can be, even if we think about medical and psychiatry comorbidity, we can define it any number of ways, but we have to define it. And it may not be the same, and it won't be the same definition for any one initiative. But for any initiative, my job as Director of Health Outcomes is to make sure that we don't implement a bunch of stuff that we can't define in the end, we can't evaluate at the end, and therefore can't scale up and implement more broadly in the end. And so that's something that's my side of the tension, if it will.
Do you have any comments, Sanjeev?
I mean, I think also part of this, Karen, would be in our training and education that perhaps that across that continuum of prevention, I think you're also talking about that there might be a component of prevention and earlier intervention for individuals who may not have these full-blown kind of disorders. That I think that's partly where we could start earlier on in some of our undergraduate education about increasing awareness and supporting the robustness of that, so that we can provide some of those earlier interventions upstream as opposed to a more focused or circumscribed group of patients.
Well, and I would think that many of the interventions we're talking about, and perhaps underneath your question a bit, Karen, is this is very broadly applicable. It's not just this group of patients. Right. This is all patients, all of us as human beings. Yeah. So over here.
Hi. Thank you for your presentation. I guess what I'd really like to do is maybe speak to the elephant in the room, in the sense that, you know, Canadian family medicine is different than American family medicine and UK family medicine and other family medicine. And, you know, there's a strong focus on behavioral health right from the beginning of integrated. You know, we talk about, you know, Canadian family medicine is based on the doctor-patient relationship. It's not disease-based. And so language such as those patients, it doesn't really work because these are our patients. And even at U of T and in the residency, there's a strong focus on building good relationships with patients, understanding, Engel is sort of, and I think we've gone beyond Engel. We've added a developmental model. So TA Glass's model comes into place. And so how do we move beyond the caricature of family physicians in this alliance? Because it's going to be hard to move forward if the language doesn't evoke an alliance. And so I wonder what steps could be taken to better understand the nature and the functioning of Canadian family medicine training, including in U of T, given this is a U of T program. And the strong focus, in fact, today there's a whole conference on behavioral health which I just came from, in teaching behavioral health and family medicine and behavioral medicine. So I wonder how the MPA Alliance can further work with the strengths and assets that exist in primary care and family medicine in Canada today and in Ontario today, so that we aren't sort of solving a problem that is actually south of the border, pretending that it's here. So it's a provocative question, I know, but I think I just wanted to wake everybody up. And given I have a new role at CAMH as Director of Medical Education, which is kind of ironic. I'm a family doc who's going to be the Director of Medical Education that could shape how we talk about this. And I look forward to it because I think the us versus them needs to come away. And we need to think about what an intertribal language would sound like. So that this alliance can go forward. So I know I said a lot of things, but hey, we've got a whole day to discuss this, and I think that's what you wanted me here for anyway. So.
And certainly tribalism was a concept from the Lancet Commission report, and even discussed yesterday.
Absolutely. Yeah. I think, Peter, I can always count on you, Peter, for a provocative comment, so I thank you for that. But I couldn't agree more. I do think, part of today, so we're talking about education today, but I think that is a broader perspective for the MPA. But I do think education can be used for us to develop some of that common language and shared language and try to co-create that. And I'm hoping that's the point today. And it may not, and I would say, for sure we have a wealth of mental health training in family medicine. I'm learning more and more and trying to integrate and not repeat as we're trying to develop MPA initiatives, because there's some fabulous work going on, but how can we make it a cohesive kind of curriculum that we share, not just in family medicine, psychiatry, but also broadly across other disciplines? I don't know, Paul, if you had any.
No, I
Hey, Benoit?
So I was not going to talk, but hearing Peter, I couldn't.
The reflexive actions.
Peter and I go back 10 years, and he has a good way to push my button. So I want to say that, Peter, I wish that what you were saying is true. I wish that, and I've spent 5 years north of the border. That's where I went to medical school, 20 years south, and back here 10 years. It's no better. It's different. It's no better. We are doing, I have a lecture on why we need a systematic approach to medical care. Usual care stinks. The one thing I will agree with you is I'm certainly not claiming that psychiatrists are better than primary care physicians. In my lecture, I am a mood disorder and late life guy. In my lecture, I show the data about people treated by psychiatrists at Cornell, one of the 10 top departments of psychiatry in the country, under usual care condition, and how terrible the outcomes are, okay? Which is basically, at the end, when everything is done, a third of those patients get better. When in any decent study, you would have 2/3 being better. And I have slides showing that you do better getting a placebo in a research clinic than getting an antidepressant prescribed by a psychiatrist. So psychiatrists do a terrible job treating depression, but primary care physicians in Ontario do a terrible job treating depression. Okay? And so please, let's not claim that we have a good way to address the behavioral problem. So to go back to the first question, which patient are we talking? To me, I'm a simple guy. I'm not an intellectual than most of you. I'm not an educator. I'm a simple guy. I come from the world of clinical trial, like to simplify the world. The MPA addressed 2 groups of patients. Yes, 100 of patients have physical, everybody as far as I know has a body and a brain. So everybody could say as physical and mental issue. But the MPA focuses on 2 groups of patients. One, who are the patient that Paul talked about. in his slide, you have an SMI, a severe mental illness, bipolar disorder, schizophrenia, severe depression, severe substance use, alcohol dependence, or severe OCD. So severe mental illness that typically impair people. And you also, that's the nature of things, are going at some point to have medical problem. Doesn't matter if it's cancer, if it's heart disease. We saw those slides that speak. And we know those people die 15, 20, now we're hearing 30 years earlier, and they don't die. Suicide account for a few years. Most of it is medical problems. So that's one side of the coin. The other side of the coin is the patient that Wayne Caton has spent his life studying. You go to a clinic, you're diagnosed with diabetes. It's fairly black and white. The medical people or hypertension. So there you have a number. The medical side changed the bar. It doesn't matter. When I was a medical student, hypertension was 160/100. We're at 125/90 or 85. It doesn't matter. Let's say you have diagnosed hypertension, black and white, based on well-defined criteria. We know that 20% of those patients will develop depression. And we know that the primary care physician do not do a good job. No fault of them, I agree. You said don't blame the patient, I don't blame the physician. Let's blame the system. But we are not doing a good job taking care of those patients. So that's two sides of the coin. The third side, because it's bizarre, we have three sides on our coin, are the patient who have said belong to nobody. Nobody wants them. The medically unexplained syndrome or symptom, the chronic fatigue syndrome, the chronic pain patient, the dizziness and vertigo. People say, I've done all my tests. It's not an ENT problem. It's not a GI problem. There's nothing wrong with them. Get them out. And psychiatrists say, that's a physical problem. It's not one of our current diagnoses. So those are the three sides. And in the end, yes, they don't constitute 100% of the patient in the system. They are, by a reasonable estimate, 20% of them. And they are the one who fall through the cracks. So to me, we have a fairly simple question to answer. One, and to your comment, I agree with you. If we were, one of my bosses, I have many of them. So Catherine Zahn say, if everybody did their job well, we would need you. We would need the MPA. So the MPA is there. It's not being adversarial, but we are fixing something. If all the psychiatrists, if all the cardiologists, if all the primary care physicians were doing their job as per the book, we would not need the MPA. So we have to agree, at least in this room. Okay? We are not with the journalist. So workshop, it's not a public lecture. We are addressing a real problem that costs years of life to people.
So this was not on the official program, but this is the debate part of the day.
We have 45 minutes for this discussion.
Absolutely. No,
so we have
thinking of the complaints from the Republican debates, I think you had a little bit more time than Peter. So I don't know if you want to rebuttal from Peter.
No, actually, I know I might have the Donald Trump kind of hair look, but I'm going to exercise my restraint at this very moment and use some inhibitory control and take my seat. But we'll the debate will carry on with Benoit later on.
And just to follow up on what Benoit said, certainly at a number of the tables yesterday, this was a very active area of discussion, really, in how the fundamental aspect of training in primary care and which is geared towards us in family medicine in Canada, how we work with that and build together there. So this is a very, very important core issue. So I think, Susan, you were next.
So I find it interesting that as a person who's devoted their career to education, my comments speak to not, I'm trying to think of what the right word is, not to overly invest of the role in education in enhancing the quality of care for these individuals, because my experience has been we create wonderful curricula however we create them, but the systems of care and practice do not resonate with the curricula that we're doing. And so my challenge to you is, and I love Eric Toppel's stuff actually, which is, the notion of the patient will see you now, is that without us trying to be active in changing how we care for these individuals in a very practical way, how we care for this population, how we care for ourselves. because it is a continuum, right? Who doesn't have emotions and mental health in association with their physical health? So if we don't advocate or work with trying to change how we actually practice, I think that whatever we do educationally will be not of great value. And I worry about sometimes us using the learners to try and change the system and exploiting them in that way, and then they get frustrated, right? Because they learn this over there, and then they go into the clinical setting, and we want them to be whistleblowers or whatever it is. So, I think that we need to think very carefully about what are some of the strategies, and I think this is within the mandate of the Medical Psychiatry Alliance, although today is about education, is what are the strategies we can use to surface existing models that are working, because there probably are some things that are working, and then to try and scale them up within our system. So those are my comments.
So if that's a nice paraphrase of the commentary that was associated with the schizophrenia mortality paper, and what they said more specifically is, so what do we do about this growing gap in mortality? Do we create more guidelines? They don't work. Do we integrate? So it was just a commentary on, we can't do the same thing. And it was a call for radical system transformation. And I think that's kind of what you're saying. But to try to embed that in and look around to see what has worked in this kind of departure from the treatment as usual, if you will, and because treatment as usual is failing abysmally. And I think so. My personal involvement of this is that I think in this particular population we have not been good at what I call journalism through data. We haven't been good at telling the stories of these individuals. So what I want to do, because we have an opportunity in Ontario, is to really quantify the gaps. Because I think that is at least shining a light where light has not existed, and then to leverage the resources in the MPA for training and for intervention implementation but to start with where strategically should we be going, and your point is a good one, which is what strategically we should be doing is what works.
If I can just respond to that also, as somebody who has an interest in leadership and systems change, is we are always very inclined to go gap-oriented, problem-oriented, and that doesn't infuse a system with energy. And so not that we don't need data is very important, but I wonder also whether we need to be doing a both and at the same time. So sometimes where we think there are problems, there really are problems, but maybe we need to be following the patient where it works and trying to do a root cause analysis of why it's working and do a both and approach, because that can be more generative at times.
Great discussion. I remember actually when Trevor came first to me and then to some of the people in this room as my executive team in terms of education, a question was asked directly of him. Where's Susan on? Susan, along that line. So we have all these existing programs. What programs further are actually needed? How do we surface them? That's a great way to, I think, frame it. And that, as we develop programs and ideas for education innovation today, if we don't think about where they're actually going to be situated and what programs we take advantage of or what new programs from a clinical side need to be developed, that's problematic. And that to me is actually one of the excitement of the MPA. That's fundamental to what the MPA is doing, because this is an education conference, but of course the big side of the MPA is the clinical models and the development and how we're working together. So go over to this mic and then back there.
So I'm just looking at a way forward from here. And I think the points we actually heard a couple months ago from Peter talking about the tribalism and Sanjeev talking about language, and also coming back to what Susan talked about, which is where is the best focus for where you begin to initiate change in the system, is in the early learners or later. There actually is a point of connection there. The main thing being that language always embodies reality, practice. That's what it grows the most out of. If we create language that is out of context with reality, that's called fiction. And so the reality is that education, where we pick our focus, where we begin to do the interventions, it actually makes great sense. And MPA has done something very important here. And actually, that's the ECHO model, for example, that it has, which is in practice learning, which has changed the clinical context first. And that's what actually drives the education that students and their early learners receive. And I think that's actually a very valid point. And as a family physician actually involved in Sanjeev's the ECHO mental health model, I think both ECHO models have been created primary care physicians in their expert hubs. And I think that embodies the reality of how we view breaking down those tribes in terms of expertise and value. So I think there's a lot to be gained, and also building on what Susan said really briefly about the focus on what's working. I mean, the whole focus on positive psychology at Harvard and all the rest is all about that, what works, rather than pathologizing the gaps in there. So that's it.
Great comment. Alison?
Thanks for the great talks. One of the things I was thinking about as you were talking about the patient population and methods of practice was the place I practiced in Ottawa before I moved to Toronto, which was with the Inner City Health Program with Jeff Turnbull, which is a sort of a team that does outreach to shelters that sees really the most ill of people with mental health issues, addictions, and very, very severe physical health issues. And a lot of those folks die very early. And I think the thing I learned as a psychiatric consultant with that team was not so much just the complexity of patients, but how to work effectively with my nursing colleagues. And I've noticed in the last couple of days that the voice of nursing is something that maybe we can't address everything in a conference, but their input and their ability to work effectively with this patient group is something we should also think about from an educational mandate and perspective. These were community nurses I worked with, not nurse practitioners, but nurses who had really figured out how to work to their full scope of practice, who learned how to work under delegated orders, who learned to work effectively day to day through just being able to phone and reach out for assistance and input from internal medicine and psychiatry and do one weekly round with them and then see these clients every single day and support shelter staff doing that. And I think there's something to really learn from that model, and there's also something to learn from an educational perspective in that as we're thinking about how to educate physicians, we need them to understand how other health professionals work. Other health professionals not necessarily in a hospital setting, because roles are very much not expanded. They are contracted in a hospital setting for all kinds of reasons. But learning maybe from some of the community team practices and a really good understanding of how we can optimize other health professional input, autonomy and leadership in healthcare teams. And that's a really important educational piece.
I mean, I would just agree, Alison. I think those are wonderful examples, and the need to think more broadly in terms of healthcare professionals. And I will reiterate that I think most of the MPA's focus has not been in acute care type of settings, because most of the care for individuals with co-occurring conditions occurs in community settings. So I think that's when we begin to really see that broader interprofessional context. So I completely agree.
So I hope, Alison, in the breakout session, focuses on interprofessional education. We could really sort of build on your comments there.
No pressure to our interprofessional facilitators now.
Leslie?
Hi, it's been a really stimulating start to the day. Thank you. I actually wanted to talk not from my educational hat, but from my clinical one, because I'm been immersed in complexity care and models of care, but predominantly for the elderly. And it seems to me that we could avoid creating yet another silo by bringing some of those people that have been spending a lot of time working on that complex group, which often has mental health issues related to their complexity, because we know what the gaps are. I think we actually don't have to spend a lot more time doing a gap analysis, and we have been working on some models of care. And quite frankly, I think the education happens where the care is happening, and if we can get that right. And just to speak to one of your points, one of the real drivers of it, I think, is how the money's funded to provide the care. And we're never, ever going to see the care change the way it needs to change, particularly from a truly interprofessional care place, until we fund care differently. And so one of the things we struggle with, and maybe between MPA and complexity in general, is we're using the wrong metrics. The government needs metrics in order to move funding the way it needs to move. So I think, to my mind, that's where we need to put a lot of our attention, and the education will follow.
Do you want to comment on metrics or employment?
Yeah, I couldn't agree more. I mean, I think, I don't think it's going to be a major topic of today, but if we just think about psychiatry and how psychiatrists are paid within our fee schedule, it speaks to nothing about complexity. It speaks to nothing about what kind of individuals we should be preferentially seeing over others. So it's an irrational incentivization process for us, and we act accordingly. So I think there is an opportunity to think about models of care and tie them into payment models. I think it's a great thought.
So my comment question kind of builds on the previous two. And what I found really striking about the slide, Sanjeev, that you showed with the 2 beds has to do with environment. And environment not only of where the clinical care is delivered, which should also be reflected in where the education is actually delivered. So if I look at those 2 pictures, as a child psychiatrist, what comes to mind is that neither one of those are particularly child-friendly. And we have to pay very, very careful attention to providing the care in an appropriate environment, but the education has to be brought there as well. Another example that comes to mind is transitional age youth. We lose a lot of transitional age youth to follow-up or to transition into the adult system. A significant portion of that is the environment. They identify that there are no safe spaces or youth-friendly spaces that they can go to that will identify and understand them and meet their needs. So I'm wondering, within the education curriculum, if there's been thought or planning towards delivering the education or providing the education in an appropriate environment that's suited to the client care.
I think that comes back to kind of the workplace-based type of learning model and really trying to create those, I think it builds on previous comments that Susan raised about finding those models of care that epitomize what we're looking for in terms of best practices for patients and families. And if we have those environments, then being able to have a more workplace-based training model where we can provide that opportunity for learners across the continuum. I think it's a great point. I also think transitions is a challenge, obviously, in our system, from youth to adult, and some of the work through Sick Kids and some of the new initiatives and grants that are being funded. I hope we're going to create these models where we can start training people in some of these transitional-based issues.
So it feels to me like we each speak to this topic from our
Yes.
bailiwicks, the things we value most highly. I vacillate in these things between inarticulate and profane, so I'm hoping I can get across a basic idea well. I think the kind of unarticulated piece here has to do with relationship. I think it has to do with the foundation of the doctor-patient relationship and the collaborative relationship between colleagues. Mm-hmm. And when that works, to Susan's point, it works really well. It's not a problem. You can have a very difficult patient on a medical floor, and if you're a CL psychiatrist with a good relationship with that floor, the patient gets managed okay. People bend themselves way out of shape for the care of that patient. Where there's continuous family practice, doctor-patient relationship, the patient can be exceptionally complex. And yet the doctor knows to focus on this thing now. And it simplifies it, right? What we got to do is get you a mammogram. You may be schizoaffective, you may have a cocaine abuse problem, but you've got a lump in your breast. How are we going to get you the mammography? And I've seen that kind of circumstance rescue many a complex, difficult issue. The problem is if you go on talking about relationship and trust and stuff, I think it feels unteachable to people or unfixable to people. I don't think it really is. I'm not going to stand up here and blast on about how I think it should be taught. But I think it's a very fundamental aspect that is actually poorly addressed by the current system. We see people with walk-in clinics in my hospital, which is an exceptionally good hospital, I dare say so. People will change, for instance, ICU staff weekly. A new person takes over the case every week. Well, that's okay if the average length of stay is 4.5 days, which it is, but it's not okay for the patients that are there for 3 months. They get a new lead person every week, right? And I think the system has to be taking into account these relational things, because that's where you get the added payoff, and in fact, that's where you get the added takeaway. One man's opinion.
Great comments.
So the only thing I would, one of my jobs when I started our mental health program at the Institute for Clinical Evaluative Sciences was to try to provide some sort of evaluation heft to the Ontario Child and Youth Mental Health Strategy. And to back up what you're saying, John, is that there was this sort of high-level notion that, wow, Toronto's so oversupplied with services and these smaller centres have very few services, and therefore the care in Toronto must be way better. But we started hearing stories about the quality of care in these small centres, and then started hearing stories about why it was better, and it was because there was only one of anything, and everybody knew everyone. And they just met around a table, whereas in Toronto, there's 20 of everything at every level, and nobody knows anybody. So I would something as complex as a child and youth mental health strategy, these places in sort of smaller centers felt disadvantaged, but they were relationally extremely advantaged as it relates to, coordinating themselves to provide good care.
So fantastic discussion. I see my button is turning yellow. I guess it's still yellow, so you can come up, Lynn. When it turns red, we'll have to stop. Yeah, right over there.
I apologize. I came in late and because I was putting out a fire, so I'm at deep risk of speaking out of context, so I'll do it with caution. But I've been listening very carefully to all the conversation, and there were just two things I wanted to say. I, as somebody who really loves medical education, feel very strongly about, I agree very strongly with the comments about having the right models of care, and then the education really starts to hum. The right models of care. And we've got some examples of right models of care. And I appreciate John Hunter's comments because, for example, I worked at St. Joe's for a very long time. Don't underestimate what they've done out there with the collaborative mental health care model. And we family physicians developed an addiction collaborative care model with the family doctors in the community modeled after the mental health program because it was so strong and it had changed everything. So now my two other comments are, one is we are in deep danger of getting into trouble in this project because of hidden curriculum issues. I just got to throw it out there because yesterday, I heard all these brilliant people describing magnificent programs, but every once in a while, there was this undercurrent of, those family doctors, there really was. And it's probably not intended, and I don't think that's the spirit of the MPA for a second. But I think we should be careful because that can have a profound impact on, as you know, on our med students feeling even will they be competent this someday, whether they're an internist, a surgeon, a family doctor, etc. And my other comment is that I do think there's a great deal to learn from Bridges. I sit in conflict because I was one of the directors of that program. For those who don't know, this was a 4-year program funded by the ministry where we funded others. We were an incubator and we funded groups involving psychiatry, medicine, and family medicine to come up with innovative models of care that promote system integration. And we had one of our wise consultants on this was Ed Wagner, who, was the father of the chronic care model. And he was outstanding, and he felt very strongly, and it played out with our Bridges projects, that the projects that were rooted in primary care, started within primary care, looked very closely at the needs of the patients, and then looked at what happens as they try to deal with the system. Those were the projects that seemed to have the greatest impact. And we did see family docs very quickly. For example, our house calls program, 6 of our academic family health teams now cover 2/3 of the GTA, providing ongoing continuity of care for people who are too frail to leave their homes, and many of them with comorbidity, so mental health and physical health problems. And we had some very elegant projects that were much more rooted in hospitals and in specialty and subspecialty or disease specific, whether it be COPD or AFib, very elegant. boy, did they struggle. I just have to say that. Often, so the patients say, why are you enrolling me in this fancy atrial fibrillation project? I already have a cardiologist. I'm not going to a second one. And then the family doctors would say, I think I'm going to pull my hair out. I now have a completely different pathway for dealing with a patient with COPD versus AFib, right? Versus, say, their substance use problem, different forms, and guess what? A lot of the time it's the same patient. So I just, those are a jumble of thoughts, but it's echoing in my mind when I'm listening to the conversation about some of the problems I think we can have. Now, is Rob Reed here today? Rob was the director of research for Group Health, which has done extraordinary work. We need to really look at who's done this well, where they actually embraced primary care. We're not fixing primary care. We're embracing it, we're enhancing it, and it's all about the patient and their families.
So thank you. And actually, we've had some good thematic discussion, some similar themes over the hour.
Sorry.
No, it's fine. Any comments on Lynn's comments?
I think it's been echoed already, but I think I agree with you, Lynn. I think we do need to find opportunities to learn from one another and to build on those strengths, and recognizing that primary care, there are excellent models of care out there. You talked about those existing shared care models, programs, and bridges, and I think within that, what we can learn from that are where are those strengths, what worked in those particular programs. I think in Bridges as well, there was the component of teamwork and change being one of the major drivers for the successful projects as well. And again, it is that collaborative effort. So I'm hopeful, again, the danger of this session is it becomes too high of a systems level, but I think it provides the context that we need to work clinically to develop those models of care, but also then what can we bring to the education lens as well.
Great. So I want to thank again Paul and Sanjeev for fantastic talks and answering some provocative questions and help getting us onwards for the rest of the day's work. So we're going to have a bit of a short break now. And when